This conference will now be recorded.
Okay, good evening, everybody. It is March the 4th, March the 4th. And this is Rick Davis. I am moderating tonight. It's the first Monday of the month. Big thank you to our sponsors who are currently Myovant, Myriad, excuse me, not Myovant, I should say Sumitovant now. Myriad, Janssen, Bayer, Foundation Medicine. Who have I forgotten? Help me, somebody. I know I haven't said enough
Blue Earth.
names. Blue Earth, thank you, and Telix. Blue Earth and Telix, thank you very much. Telix, by the way, is kind of exciting because if you've been reading the reminders, we're gonna do a special with them on their alpha particle radionuclide that's married to an antibody and looks like it could have some real legs and is also an alternative if you're not getting further with Pluvicto. So that should be great. I think probably we should just dive in, and we have a couple of faces we have not seen in a long time. And for that reason, I think, well, one medium long, not long, not medium. So, and a Brains Trust member, and the other for a long time. So we'll start with those two, and I'm going to kick off with Dr. Bob. I will say, by the way, Dr. Bob, that we have I think we have an event in Philadelphia at Fox Chase on the 13th of March, and we're going to have a table there, and everybody who might be in that Philly area are welcome. Tell your friends. Alan Babcock is going to be kind enough to man the table, and we're looking to see if we can get a couple of other people. And they will feed you. It's at 5:30, and the information is in the reminder. And if anybody needs the information directly, they can reach out to me. So, um, Bob, tell us what's going on with you.
Okay. So I did see that about Fox Chase on the 13th, and originally I couldn't make it because originally I was supposed to have a Pluvicto shot 3 days prior, 2 days prior. But
Uh-huh.
as it turns out, just when it looked like Pluvicto was starting to work, it wasn't.
Oh.
So my PSA went from 60 to 90 after the first Pluvicto, back down to 60 after the second. 10 days after the third, it was at 30, which sounded good. And then 10 days later, it was 63. And a week later, which was last week, it was 75. I got
Mm.
scans last week, CT, bone scan, and PSMA PET, and they all showed progression. So Pluvicto isn't working, and so that's off the table now. Met with my oncologist. All my mets are in bone, so a week from tomorrow, I'm getting a bone biopsy of one of my mets from the hip. Uh, Plan to send that to Boston Gene to get RNA, DNA sequencing. Um, there's a company called Sage Medic that I was able to connect to, and they are going to try and do functional testing off of the bone biopsy tissue. And and then from Boston Gene, if they can get material that they can sequence, they're going to send all the raw material to a company called Cellworks, which does biosimulation. And what they do is they look at all the proteomics and all the mutations, and they run it through all the different pathways and try and simulate what drugs may work and what drugs may not work. And hopefully between that and functional testing and the sequencing, we can come up with something that maybe will work. All that's going to take time. So in the meantime, there's a probably good chance in the next week or two that I will start cabazitaxel, at least 1 or 2 sessions. So that's the gist of it. I'm just trying to coordinate everything between, because for the sequencing, they need to have the tissue handled slightly differently than a normal path department does. And I got to try and reach out to the radiologist who's doing the biopsy to make sure he knows that he needs one portion to go into formalin and one portion to go into saline, which I'll be bringing. And so there's a lot of moving parts that I'm trying to coordinate, and I've got about a week to get that done. So,
I have one thing I'd like to raise with you, but
sure.
That said, I'm sure there are some people in the group right now who have questions on all these tests you're doing. Has anybody want to talk to Dr. Bob about the strategy and the testing that he's doing?
Yeah, my point in doing this, and I'm able to get all this stuff done for free, so it's not like it's costing me a fortune, is the more data I can get, the better. How I use it, whether I use it, remains to be seen. But
Well, how do you get it done for free? I'm sure there's a lot of people that would like to know that.
so I was able to. These are relatively new companies, and they're looking for data. And through, from one to the next, I was, kind of like, okay, you should talk to so and so, and they're like, yeah, we can try it. Especially the functional testing. Nobody does functional testing on bone. This one company is willing to try it because they don't know if they can do it. They're not going to charge me.
Okay, so explain to everybody, including me, what is functional testing?
So that seems to be a pretty new concept where they take live tumor cells and sometimes they will grow it, sometimes they will separate it out, and they will use different drugs on the actual cells in, in a petri dish and
Right.
see what kills quickly, what doesn't kill, what kills slowly, to get an idea of maybe there's a drug that we're not thinking of that might work. They're looking at the typical drugs, docetaxel, cabazitaxel, carboplatin, but they're also looking at some repurposed drugs or older drugs. And I was talking today, and I forget the name of the drug, but whatever the standard of care chemo before docetaxel came out, in functional testing proved, or it was shown to work the best, and the person who failed docetaxel and was about to do cabaza used this other older stuff. It was basically standard care from 30 years ago, and
Right.
got great results. And they never would have considered doing that.
Right. I'm trying to remember that it wasn't etoposide. Len, do you remember what was that drug they used before?
It begins with an M, but I just can't think
Yeah, it
of
does
the.
begin with an M, and I don't remember the name.
Yeah, I can't recall either. I believe they use it in breast cancer.
Yeah.
And they did use it in prostate cancer before docetaxel. You're right. Now it's interesting, Bob, that this functional. I wrote about this in our AnCan reminder just, I don't know, 2 weeks ago.
Right, I saw that.
Yeah. Are you using any of the companies that were mentioned in that piece that I did, or?
You know what? I don't remember the companies that I, 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 I reached out to a few of them, or I looked online. Most of them will not touch bone sample. This
Okay.
one, I was referred by Boston Gene to this one company, and I spoke to the CEO today, and he's like, theoretically, it's possible. We're willing to try it if you are, and we'll see what we get. You know,
What about if that doesn't work? Can they work with liquid biopsy material?
I don't think so for functional. What they like is, some cancers produce a lot of either mucus or liquids. If I had osteolytic lesions in the bone, that they could draw from, but everything I have is osteoblastic, which is what prostate cancer does to the bone. So,
Right.
because it's questionable whether they can do it at all, they're, you know, this is pretty much a test case for them. So, and like I
But
said, the other company that's going to take all the raw data from the the sequencing. This company is called CellWorks. They do this biosimulation. It's all computer driven, and they're a relatively new company out of California, and they're looking for data, and they're looking for what they predict, and if I go with what they predict, how well it works. So that's the reason why they're also. That's it. Mintoxatrone.
That's it, Metoxantrone. Thank you, Jimmy.
Yeah.
Thank
So,
you, Jimmy. Good job.
I figure I have nothing to lose and maybe something to gain. And in the meantime, if I have to do a couple rounds of cabazitaxel and that shows up to be something that'll work, great. And if something else shows up better and the cabazitaxel doesn't seem to be working great, then hopefully my oncologist seems to be willing to go somewhat outside the box. So
Um, so who is the company that's doing the functional testing for you?
they're called Sage Medic.
Sage Medic. Okay, yeah, you mentioned that. Um, so a couple of things. One is that even though it was a very small sample, they did find that people that followed up Pluvicto with a chemotherapy responded well. So that was out of McGill in Montreal. Um, but the more interesting thing for me, and maybe this will be the timing will work out great, is what I was talking about before, which is the use of an alpha particle radionuclide married with this 591 antibody. So as long as you are PSMA avid still at that point, um,
Yeah. I mean, right now that's only available in this country in a few places and trials. So,
okay, so let me finish.
oh, I'm
So
sorry.
so Telix is testing this worldwide. They're already in trial with it in Australia, and they are planning on opening up several centers around the country in second quarter, which is when we're going to do the webinar. Now, what's interesting about it is you only need 2 infusions as opposed to 6. And there are a lot of other advantages too. One of the things that we've seen here is the response that Jim Barnes may have gotten out of using actinium in Germany,
Mm.
which
I,
seems like it would be somewhat positive. But if we do this Telix stuff, you're going to have an inside track,
yeah,
um, and I will start making the inquiries to see when and where they plan to open it up.
yeah.
Um, but
I,
you
you
know,
know, I was going to say, well, two things I have to, well, one thing I have to keep an eye on is the effect on my bone marrow, because,
sure,
you know,
absolutely.
it's already gotten beaten up a little bit, not terrible. Actinium is going to beat it up a lot more than Pluvicto will, most likely. And it's certainly something for the
Maybe.
future. You know,
I
I'm
mean,
looking
they
at all
haven't seen,
avenues.
in theory it should, but they haven't seen that response. So I can't say yes, I can't say no, but I
Hmm.
understand why you say it, but they haven't seen it. Possibly one of the reasons is because it's a lot more focused and there's a lot less of the radiation covering areas which are not damaged. So I don't know, but it certainly we'll keep an eye on it. The other thing is that and this should come out of or if it doesn't, I would say make sure they have enough tissue so that you can get a pathologist's eye on your bone tissue. Now,
Hmm.
the problem is this: if the bone tissue could show normal, but your cancer could still be morphing because neuroendocrine small cell morphing neuroendocrine cancer, it's not consistent around the body. So you could have it in one side, but you might not have it in another, and that's always an issue. Um, it's a problem with this DLL3 stuff that they're doing at different places around the country because they're basing it on biopsies, and that's not a great source to determine. But that said, I really, and I know you've looked at it before, but I do want you to keep a real eye out for this small cell morphing situation.
Yeah, I mean that's part of the reason why I'm doing more than just having him look under the microscope. Getting the sequencing.
Okay. All right. Anyone else like to talk to Bob about this interesting approach that he's taking, creative, inventive, and hopefully will produce solutions? Peter, do you want to say something?
Yeah, Bob, how's your doc at in Philly responding to this?
Um, so far she's on board. Uh, you know, I haven't heard back about the functional testing only because I just talked talked to them this afternoon. So I have to hear back, but she's all on board about getting, the sequencing. Um, you know, and when I brought up the idea of it was my idea about getting a bone biopsy to see what's happening with my cancer. She agreed that that was a good idea to get a look at where I am now. Um, I'm not looking forward to getting a bone biopsy, but I think that'll give us a lot more information than going off of what the genetics was almost 2 years ago.
Right. Yeah,
So,
I mean, you and I are unusual cats. I mean, you've got a much more serious disease than I do, but I mean, we both take initiative to suggest things to our docs that are a little bit beyond their thinking or their toolboxes, which is cool. Um, I mean, that's what I'm going to talk about when I come up. later. It's an interesting approach. I mean, it's really being your own best advocate in a dynamic way, and I praise you for it. It's great that you're doing the research and looking and taking these steps.
Yeah, you know,
Len, Len,
where it will
would
take
you?
me, I don't know, but you know, like AnCan always says, be your best advocate and figure more data is better than less.
Right,
Right.
Len, would you like to put Dr. Bob's mind at rest a little bit about the bone biopsy?
Yeah, Bob, I had a bone biopsy at the NIH, and it was no big deal.
Okay. Yeah,
Um,
I've heard it's not a big deal. Um, they're going to sedate me. I was a little surprised when they said the procedure, including the sedation, takes an hour and a half, but whatever, if I'm asleep, I don't care.
not the actual procedure, maybe recovery if they give you sedatives. Depends how much painkiller they give you. They actually gave me only a mild sedative. I was completely awake and I could see the fluorescent screen. I forget what they call it. I could see what they were doing,
Hmm.
banging through the bone. But it did. My body was shaking a bit just from the physical force, so that freaked me out a little bit. So I said, "Okay, guys, you can. It's okay if you give me a little fentanyl." So they did that. But I mean, it was all over in about 15 minutes, really.
Okay. Yeah, I don't know. I'll find out. You know, they're taking it from the hip, which is where I have the worst Mets, and I guess
Yeah,
that's a good place to go.
yeah, yeah. That's where mine was.
How are
Yeah.
you feeling physically?
And
Bob?
not too bad. I do have some hip pain off and on. I'm not able to walk as far as I used to, but I'm still able to walk 2, 3 miles before it starts, getting pretty uncomfortable. So other than
Okay.
that, Pluvicto side effects were pretty mild. Really, the only side effects I'm on a pretty high dose of oh, what should we call it? I'm hitting a blank. Gabapentin, and that's
Hmm.
given me dry mouth, which is annoying.
Hmm.
The one thing you mentioned about actinium, Telix, 2 doses of actinium will probably kill permanently salivary glands.
Well, again, I don't want people to go away from this call thinking that's the case. We discussed it at some length. I was in an advisory board with Telix, and Dr. Leno was there, Lenzo was there, who's had a lot of experience, and it's not clear. I wouldn't say that they've had experience where people have done no worse than they do on Pluvicto.
Mhm.
But so yes, it can be, but again, it's not a fact.
Yeah, and if it works, it works, and that's, dry mouth is, you deal with it.
Tony Fig.
A few weeks ago, we discussed the fact of using a liquid biopsy as compared to bone biopsy. Is there certain criteria or certain diseases when the liquid biopsy would not yield as good results?
So I'm glad you brought that up because it went through my mind as Dr. Bob was talking. If it were me, I would also do a liquid biopsy right now and send it out to say FMI or Tempus for comparison. One of the reasons for that is because a liquid biopsy gives you um, a much better picture of your whole body, of the whole metastasis. And
Yes.
And so there's no harm in sending out a liquid biopsy at the same time and seeing what result you get back on the liquid biopsy and how it compares. I think for the purposes that Dr. Bob is talking, he needs tissue. So that's why some of these people that he's talking to as can't work with just blood, as Len raised earlier on.
Yeah, and that's something that I'm certainly going to consider. I had a liquid biopsy shortly before starting Pluvicto, so that's something that's certainly still on the table.
What did it show?
I had a mutation in the SPOP,
Mm-hmm.
and FANCM. Um, one has one potential actionable. There's a trial that is potentially actionable in one of those, but neither one's really actionable.
Yeah. Yeah, there's something going on with SPOP. I do know that, but I don't know anything about FANCM.
Well, I think that's Fanconi's
Yeah,
M, and I think that's part of the DRR cascade, DNA damage repair. So I think some of those Fanconi sequences might be sensitive to PARP inhibitors. But anyway,
yeah,
talk to your doc about that. But as far as the actinium in the salivary glands go, Bob, my understanding was that if they use a large molecule linker, like a monoclonal antibody, instead of a small molecule, that it
Yeah,
doesn't, yeah, it doesn't find its way to the
correct.
salivary glands so easily.
okay.
Correct.
Yeah, I
Yeah.
mean, I just know that the current version of actinium is pretty bad for the salivary glands, but
Well,
what Telix is coming up with may differ.
yeah, I mean, I think as exactly as Len says, you have to distinguish between the small molecule and the large molecule.
Hmm.
And that is one. But we will sort all this out when we do our TLIX webinar, which I think will probably be next month or maybe in May, but I think the sooner the better. And so we're trying to arrange it. All right, I'm going to keep rolling, but that was a very interesting start. Dr. Bob, we wish you the very best.
All right, thank you.
And if anybody gets to Philly, maybe, and if Dr. Bob is feeling up to it, maybe you'll get to meet him in person. So, Dell, what's going on in your world? We haven't seen you for an awful long time.
So greetings. I just got a Lupron shot this morning. My PSA back at the beginning of February popped back up to zero point 0.6. And so basically, I back in April of last year, I finished up 18 months and went on a drug hiatus to go for the summer. Um, at that time, my PSA was 0. Um, my oncologist right now at Northwestern is Dr. Vanderweely, and he wanted to see what a PSMA scan looked like after 18 months of Lupron and abiraterone, and I was undetectable. Even the bone met was not detectable. And I asked him, well, if my PSA is 0, is anything going to be detectable? And he says, well, I'm not sure, but I'm really interested in that bone met because the bone met was there before, and he wanted to know if that would still show up even if my PSA was 0, and it didn't. So the PSMA PET scan showed nothing. He says, "Yep, you're free to go ahead on your drug hiatus." It lasted 10 months, about the same length of time as I happened the first time around when I was under the care of Alicia Morgans. I had asked her back in November of 2020 if I could go off, and I went off for about 10 months, and the same thing happened after about 10 months. Um, the key for me, testosterone gets over 300, PSA rises. That's there's a direct correlation. 300, 350, and then my PSA starts to rise. So I'm definitely still, what is it, hormone sensitive. And my main question is, if I'm just doing Lupron and my PSA still set is staying at 0, is there really any purpose to Zytiga or Xanthia, or is there any benefit there?
Did he do a PSMA scan again before he put you back on to see what was generating?
No, I don't see him until April, and it won't be. They will only do one every 18 months. Uh,
Why? Since when?
well, I don't know. When I was with Blue Cross, they said every 18 months was what they would
No,
do it.
that's not the case. It's as needed. It's
Okay,
as needed by the doctor. And
okay,
frankly, I would get one very, very quickly. But did you say you had the Lupron shot this morning?
yes,
Well, there's a couple of things. First of all, did you do bicalutamide for 10 days before the Lupron shot?
no.
Okay, well, you know, again, Vanderwheeler should have had you do, he doesn't know where your Mets are, and he should have had you do a buffer, unless you did, an antagonist like Orgovix or Firmagon. But if he gave you Lupron, he should have given you a buffer first, and that's
So,
disappointing.
so this is my local oncologist. I have a local oncologist. It takes 2 months to see Vanderweely, and I had him scheduled in
Okay.
April of last. I had him scheduled since November for April, and my
Yeah,
1 year follow-up.
yeah, but Del, this is why we tell you don't use your local oncologist, because that's an error. That's an error.
Okay,
It's an error because you're going to get a surge in testosterone from the Lupron. If anything, he should have given you an antagonist. Should have given you Firmagon or talked to you about going on the Orgovix pill, which is a much, much better option. But you see, the problem is these local oncologists don't know. And then
I,
they put you in a difficult in an impossible situation. Now, God willing, nothing bad will come out of it, but that's not the protocol when you put somebody back after 10 months. That's number one. Number two is get a PSMA scan immediately before your testosterone switches off, because we want to know if we can see where that PSA is coming from. Really,
okay,
really, it's a good opportunity now. And again, should have been done before you put on the Lupron. I mean, these local oncologists who don't deal with prostate cancer, they have their head stuck up their wazoo sometimes. And you got to talk to him and say, I need this right away. You're going to have to get it done. You got to say we need it, and hopefully this week you'll get it. And it should be before the Lupron does anything, because the Lupron puts more testosterone into your body before it drops it. That's the
okay,
reason why you need the buffer. I
okay,
would also, I think, I don't know, I can't give you medical advice, but I think that if it were me, I'd want to be taking bicalutamide tomorrow morning. Call him up and say, I want to take Casodex right away as a buffer, because the
o-
Lupron's going to take time, and at least for the next few days, you might be able to create a buffer. You might not need it, and I'm not sure about taking it simultaneously, but it's something that I would consider
okay.
and needs to be
So
discussed.
the PMSA PET scan is not available locally, as far as I know. I have to go to Chicago for that.
I doubt it. Not now.
Not now?
I
Okay,
No, not now. I mean, now it's pretty much available everywhere. And I can't
okay,
look right now, but I can look later. But I had a map from Cardinal that showed where it was available. I would bet dollars to donuts it's available locally now.
okay.
It'd be in
This is
Iowa
like,
City anyway.
Iowa City, yeah.
so, that Iowa City, how far is it? How far away is Iowa City?
It's an hour. I had a really bad experience at Iowa City.
Okay. Well, there's going to be other places, and
Yeah.
and and they're making it available, but but these are important steps. Dr. Bob, you have your hand up. You're muted, Bob. You need to take yourself off mute.
Yeah. So he also asked about whether he needs Zytiga or Standy, and
Yeah, we didn't get there yet. And the
yeah,
reason we didn't get there yet is because he needs a PSMA scan, and then we can probably decide what should go with it.
yeah. So theoretically, if his testosterone is really low based on just Lupron, and his PSA is rather low, might it be better not to use one of those because they tend to stress the system and increase the risk of small cell differentiation, if I'm correct?
Well, I mean, I this is the old argument from 15 years ago. Don't give people the drugs because they're going to become resistant too quickly. But the tests that the clinical trials that we have today indicate that when you resume, you should resume with doublet therapy, or with chemotherapy if you have multiple um, lesions. And I think that the success using doublet therapy would go against what you're saying. I mean, it's continued use for a long time that might do it. But I don't know, Len, what would you say on that one?
Yeah, from the GU ASCO 2024, we saw once again proof that adding the second line anti-androgen to ADT is consistently uh, superior to ADT
Yeah.
alone in progression-free survival. And that goes for abiraterone with ADT, darolutamide with ADT, enzalutamide with ADT, and apalutamide. So any second line anti-androgen added to ADT is uh, more efficacious than ADT alone.
Um, and Dell, that would be my response. Yes, could you morph more quickly? But you're a long way from that, man. And and your disease doesn't indicate it. Go ahead.
Oh, nothing. The my last PSMA PET scan where I was active, my PSA was 1.6. It was 2 months after I had become, and basically the PET scan was just very into, how do I say this? The doctor basically says there's like 6 to 8 spots and there's one bone met, but his comment was it's very low volume disease, meaning there's these spots, but when you with the CAT scan they couldn't even detect the the cells where they were seeing the activity, whether it was which lymph nodes were involved and stuff like that.
Yeah. Well, I think if it were me right now, I'd get a PSMA scan very, very quickly whilst your
Okay.
testosterone is still present.
Okay.
And I'd be talking to this doctor maybe about a bicalutamide buffer. They usually give it you for 10 days beforehand, before they give you the Lupron. So, like I say, I don't know. I don't know enough. You might want to ask Vanderweiler, tell him you got it. You didn't get a buffer. Is there any point in starting it now? Because he will know the answer to that. And
Okay.
I'd be talking about getting a second line if it were me, I'd be wanting to go on a second line anti-androgen based on the trials. And if I could get onto darolutamide, that's probably what I would ask for, or abiraterone.
Okay.
And then, given your history, hopefully you can take that for 12 months or so, and then maybe you can do another holiday again.
That's my primary discussion with Dr. Vanderwilly next month is I want to know what do you recommend for this? Because I mean, just it's not great when you're on it. I
We
had a I
know.
had a fantastic summer. I had a fantastic
Now,
summer.
look, there's another strategy to review with Dr. Vanderweiler, which is a monotherapy second-line anti-androgen. Forget the Lupron, but maybe do monotherapy darolutamide or monotherapy abiraterone. We've got a bunch of guys doing that. And your local guy will not, that'll, I think, probably be beyond him, but we have I can't remember I can't remember if Len's on monotherapy or
Yes.
Len, you're on
Yeah,
monotherapy.
I'm on
So what
monotherapy
it
darolutamide for the second time in the past 5 years. It's still working
was that is so that without the ADT?
without ADT.
Okay, so just the
Mono,
abiraterone or
Yes.
yeah.
Yeah, I'm
okay.
the same.
In my case, darolutamide.
Harry,
Yeah, I'm the
go
same.
ahead,
Darolutamide.
Harry.
I am the same, just darolutamide only. And it's been 2 years now. It's working well.
Okay.
So, these are real good. These are real good options. We needed you last week, not this week.
I yeah, it's tough. I've got my life is busy. I'm teaching full
Good.
time and still doing scouts. I did a camp. Literally last weekend, I spent the weekend in a cave with
Okay.
7 scouts.
That's
So
we love to hear it.
I'm just living it, and
Okay.
I most Monday nights I'm either at my daughter's scout meeting or I'm at a committee meeting. And so tonight I had my son is home from spring break, so I had him take her to scouts.
Good. Okay. And there's always Tuesdays, which maybe you have a
Tuesdays is
different.
scout nights.
Okay. All right. I give up. But worst
I
case,
know. Yes.
worst case, you
And
can
there's
always
also
act.
Thursdays.
Okay.
There's
All
also
right.
Thursdays.
And there's also Thursdays. All right. But you got your marching orders now, right? And
I
please
got
keep
it.
me posted. Okay.
Will do.
Thank you. Anything else for Dell? Anybody else have anything for Dell before we move on? Okay. We're going to
Joe,
start.
Joe has a question.
Joe, go ahead.
Yeah, I wondered if you could talk briefly about the advantage or the reasons for doing just the non-ADT drug. I'm not going to get my terms right, but as opposed
Yeah.
to the combination.
Well, I mean, I think the biggest thing is that it probably has lesser side effects. Um, it's debatable because you have testosterone going through your body, but the androgen receptors are blocked. So in theory, it shouldn't make a difference. But the guys feel better on it. I'll let Len. Since you're doing it, I'll let you answer that one.
Yeah. So what you get, and I'm going to only speak for darolutamide because I wasn't taking any of the others, but you have a lot less fatigue than when you're taking it with ADT. Your T levels will be in the normal range. Your blood counts will be better. You're less likely to suffer osteoporosis. It'll be easier to maintain muscle mass. These are and again, everybody's different, I guess. But in my case, I have no hot flashes. when I'm on darolutamide monotherapy. So those are the advantages. Do you feel some fatigue? Yes, definitely. Compared to I was on a drug holiday for 21 months, then I went on darolutamide for the second time as a monotherapy, and I did feel more fatigue, but you can't have everything.
Can I ask you a question?
Go
About
ahead,
that?
Jack.
The estrogen level, have you ever measured your estrogen levels since you've been on darolutamide alone?
Estrogen levels? No, no, but I don't have gynecomastia, never have. And I don't know if it has anything to do with my anatomy at the time that I began darolutamide, but like Dr. O said, I said, I'm worried about, being on monotherapy with darolutamide and developing gynecomastia. And he said, I can tell just looking at you, it's not going to happen. He said, you don't have fat cells in your chest.
Well, as you were talking about osteoporosis and being less inclined to have that, and as you were just in general, it seemed to me that could be symptomatic of the fact that you're not blocking off the luteinizing hormone at the pituitary level, and therefore you have high testosterone still and high estrogen too. So therefore, in general, your sense of well-being is greater. But the biggest side effect I could see being the high estrogen level, since the testosterone receptors are blocked off, but the estrogen receptors are not. So I'm just, whether it's gynecomastia or less osteoporosis or whatever, hot flashes, less hot flashes, which are caused by, lack of estrogen, not lack of testosterone.
Yeah, that's a good point, Jack. That may be why, that may account for some of the, let's say, lack of symptoms that I have.
Sounds
My
great.
estrogen levels may very well be higher.
I certainly hope to get to that point where I can go on solo darolutamide. He said after 2 years, maybe we can do that.
Yeah.
Thank you.
All right, we're going to move along. This is all real good discussion. Not just for you guys, but for the people that listen in. This is really, really helpful. So let's go to John Kish, who's on the phone, and have John give us a quick update because I think he's back on treatment again. John, are you there? Can you unmute? Yes.
Yeah, can you hear me?
Yes, we can.
Can you hear me?
Yes, we can.
Hello? Oh, okay. Yeah, I was on Lupron for 2 years and off of it over a year, and I went to Philadelphia to see Dr. Narayan. Well, my local doctor has me on enzalutamide for about 2 weeks, just as a monotherapy. So there is some fatigue, but not as much as the Lupron. So.
And how long have you been on this enzalutamide monotherapy? You said 2 weeks, is that right?
Yeah, 2 weeks. Yeah, maybe it's too early to tell, but there is some fatigue, but not as much as the Lupron,
Okay.
Yeah.
And what did Dr. Narayan say to you?
Well, he was saying that my local doctor could give me enzalutamide now. It's approved just as a monotherapy, and they approved it at University of Penn, and I guess for all Pennsylvania it's approved now too. And then my doctor he didn't believe, he didn't want to try anything else besides Lupron, but as soon as Dr. Narayan sent him the info, he was like, he seemed happy to be putting me on this. So I guess my local oncologist learned something new, because
So
when I would mention to him, he wouldn't do it. But when the doctor mentioned it, then he seemed interested. Yeah. Okay.
So
sorry.
it was Dr. Narayan who came up with this strategy of monotherapy enzalutamide?
Yeah, and he said instead of traveling to Philly, I'll send the stuff to your local doctor and he could do it. And then they were really willing to try to do it up here now. So I guess all they needed was a proof that it's approved, you know. Because when I would mention stuff to him, you know,
Yeah,
he wouldn't listen to me. But
yeah,
once a doctor said there
yeah.
was
But
proof
John,
for it,
this is exactly the reason why we tell you you cannot rely on your local doctors. We've heard it twice
right,
tonight. You've got to go to a GU medical oncologist because they know what the latest and greatest is. And this
right,
is another very good example of the guy wanted to just put you on Lupron. I mean, there was a paper at GU ASCO that I think it showed that I can't remember the percentage of community doctors. It was like 80% of the community doctors did not add a second therapy, didn't even know to add a second therapy, whereas 80% of the doctors at centers of excellence do. And this is why we push people towards. Do you have any questions about this monotherapy enzalutamide, John?
um, I just what are the main side effects besides fatigue that are common?
Do we have anybody who's done monotherapy enzalutamide here?
I'm on enzalutamide right now. Me, Peter.
Yeah, Peter,
I'm
monotherapy or with Lupron?
monotherapy, just enzalutamide.
Okay,
I've been on it since September.
Okay, great.
It's you get used to it. First 2 weeks I felt a little off, but you get used to it. No hot flashes. The fatigue I feel is more at the end of the day, like at night after dinner. Um, for me, it kind of acts almost like a stimulant when I first take it in the morning. I take it with breakfast. Um, but it's a lot more tolerable than the Firmagon, which is what I was on last year. A lot more tolerable. My PSA seems to be going down. I got my next round of blood work in the first week of April, and we'll see. We'll see.
Okay. Well,
But
that's good
a
to
lot more
hear,
tolerable.
and that's encouraging for John Kish as well.
Yeah. It's the Firmagon was miserable for me. But no loss of muscle mass. Um, just yeah, but if the only tangible side effect really is my nipples are so fucking tender.
Yeah.
It's the weirdest thing, and they just laugh at me and say, "Yeah, that happens." So
Well, yeah,
okay,
that's part of what we were talking about before with the
that
estrogen.
word that Len used, right? The mass something.
Gynecomastia. Yeah.
Yeah. I don't really have the vocabulary to participate in these conversations. That's why I
No,
just
you
listen.
do. You're just fine, and we're so glad you're here today because it helps John Kish as well. But
Right.
I think some people will respond, and others do not, and so Len is good on a monotherapy, and for you it's tougher, and that is a risk of a monotherapy, yes. So, but the other side
It's
of it is that you don't have hot flashes, so
I know hot flashes. I haven't lost any muscle mass. I can
right,
still work out. I work out every morning. So
right,
it's not bad. It's not bad.
right.
I've actually lost 10, 15 pounds since I've been on the enzalutamide because I put on a lot of weight on the Firmagon. I put on a lot of weight,
Yep, yep. You're not
and
alone.
and it's slowly coming off.
All right. Well, we're gonna keep pushing through here. Tony Fig, what's on your mind today?
Well, I've been going through quite a lot of mental turmoil lately. Uh, 4 weeks ago, I had to have the leads in my pacemaker and the pacemaker replaced. And in the process of it, both of the leads broke and they had a tough time getting them out. And as a result, it tore two parts of the tricuspid valve in my heart. So I've got to get it surgically fixed or repaired. But in the back of my mind, I've been really thinking what happens if the PSA goes up and I have to go back on hormone therapy. That's going to interfere with surgery for the valve and everything. So today I had a blood test and the PSA is less than 0.02, which is fantastic. So I'm very happy with that news. And the testosterone is up to 494 now. So it's been 11 months since I was on Firmagon. So I'm just really happy with that good news to offset the other news.
Okay,
So that's
well,
the update on that.
as we always say, David Muslin isn't here today, but we can invoke his name. You got to stay in the present, and the present presents a really good alternative for you right now, which is to go on with this, to do this heart surgery, and we wish you all the very, very best with this heart surgery. It sounds like it was really a bummer that it was really unlucky what happened and when they tried to replace the pacemaker.
I've talked to many people in the cardiothoracic area, and nobody's heard of this happening in many, many years. So it's a result of the leads had fractured, and the breaking of them is what caused the main problem. So they kind of had to fish them out, lasso them out.
So how long will the procedure be?
It would probably be only about 4 hours. It could be non-invasive or it could be open heart, and then it's
Okay.
about a 5 month recovery.
Oh yeah, well we hope it's non-invasive. We hope it's
Right.
non-invasive.
Yep.
Any questions for Tony on anything that he's raised? Well, we like the prostate cancer news, Tony,
Yeah, that's
very
great news.
much.
Mhm. Yep.
Okay. So I'm gonna keep going because we got time, but we got quite a few guys. General Joel, what are your questions tonight?
Okay, let me start off with Dr. E again. She gave me a blood test on 31 January where I had a lot of red on it, including low white blood cells and platelets and red blood cells, which I reported a couple of times ago in this room. As a result, she was very concerned about the white blood cells. So she gave me another test, which the results came in this morning. And the red blood cells have gone up from 2.4 to 2.7. In the meantime, the Veterans Administration canceled the FDG PET scan that was supposed to take last Thursday on me because the machine broke. So I don't have a new schedule on that yet. But something else happened to me. I was eating a meal at a restaurant, and I do this infrequently and not on a regular schedule, but sometimes I'll check my pulse. Not necessarily at a restaurant. I just do it when I think of it. And I thought my heart was beating kind of slow. And I looked at my Apple Watch, and lo and behold, according to the Apple Watch, my heart has been beating between 46 at a low of 46. I used to be at a low of 58 for many years. Now I'm at a low of 46. And so I was concerned. I wrote to my heart doctor, cardiac oncologist yesterday and this morning. So I happened to have an appointment with my primary care doctor today and this morning also. And uh, both of them, well, she said that she would lower my atenolol from 50 mgs a day to 25 a day, and she would up my amlodipine from 5 to 10 mgs a day, and that should take care of my low blood count. So hopefully that'll work. Told her by my ultrasound of the VA where it said my liver, spleen, and gallbladder were inflamed. Even though I didn't have cancer there, they were inflamed. And she's of the opinion, like another doctor I have, that it's the darolutamide causing this. Dr. E thought it may have been, she wasn't sure, but it may have been the radiation I took in November and December, the 4 series of SBRTs that I did back then, which affected my bone marrow, which is why my white blood count was low. So that's where I am as a situation. I haven't talked to Dr. E yet because I want to wait for these results to come in. So the question is, I even called a Credo Pharmacy, who is a specialty pharmacy that supplies me with darolutamide today. Of course, they wouldn't commit to anything, but at least they took a report about my issues. My blood pressure in the meantime also, because I was on Mounjaro, I lowered my weight by 25 pounds exactly in 3 months, but then I got allergic to Mounjaro, so I had to stop. And my the heart doctor had lowered my meds because I was taking too much medicine for my blood pressure was getting too low. But now my blood pressure is around 181 over 81 last night with a heart rate of 46. So anyway, so I have some blood pressure problems. I have, as I said, white blood count problems and other issues, all that merging together. So again, I researched it. Darolutamide definitely causes white blood count to be down. It also affects inflammation in some body parts. So I have a couple of questions. Should I propose to Dr. E to put me on 2 pills a day of darolutamide instead of 4? And number 2, has anybody here in the room had a situation with low heartbeats before? And what have you done about it?
Okay, so my answer to the first question is I wouldn't be telling Dr. E. There are some docs I might want to instruct. I wouldn't want to instruct Dr. E. I would ask her whether she feels the dosage is right, or does she think it's appropriate to the darolutamide. That's what I would do. But everybody makes their own decision, and we'll throw it open to people right now. Frank, do you want to talk about one of these 2 issues?
Yes. Joel, back in 2013, when I had breast cancer, I went in for surgery. During the operation, my heart rate went down to about 35. And they called a cardiologist in. They continued with the surgery. Afterwards, they thought that it was an electrical connection to my brain, and they wanted to wait a couple days until they saw if it reconnected, and the blood rate, the pulse went up. They waited for about 2.5 days. They didn't, and then they moved. They called it bradycardia, the condition, and they immediately went and put in a pacemaker And since then, my heart rate has been at about 58 consistently because my pacemaker paces at almost 100% to keep the rate up. Rather than adjust, I'm also on atenolol. Rather than try to adjust that, they decided that the pacemaker was a better route. And I've gone through one pacemaker and just had, after 10 years, had a new pacemaker put in. Luckily, the leads were okay, and I didn't run into the problem that I heard earlier, and they didn't have to replace the leads. But I don't know if they had any discussions with you about a pacemaker.
No, not yet. This has only been for a couple of weeks now, as far as I can tell, that my heartbeat has been down. I did read that on the internet today that the pacemaker would be a way to go if it persists in staying down. But no, I have not. I have a office visit with my heart doctor on 2 June, I think, and he's given me a couple of heart tests before then. So he sees me every 6 months. So,
Well,
but
Joel, you may want to bring that forward based on what's going on. I mean, I think there's
yeah,
every good reason to bring that forward. Peter, what's on your mind?
I was just going to say that I did half dose darolutamide for quite a while. I think maybe Len did too. I don't know, but Len and I talked about it. But I had no problem with it. It worked pretty well for me. It got rid of a few of the symptoms I was having.
yeah, I heard in this room several times that darolutamide. I'm 8 months out from getting off of darolutamide up to 2 years, but I did hear from many people, well, some people in the room that darolutamide gets worse and worse as time goes on. The symptoms get worse. So, the results of my last PSMA and whole body MRI from Dr. E in Houston have no discernible cancer, and my PSA has been undetectable for the last 8-9 months. So I'm okay there so far. I'm holding still a level there, but yes, I am concerned, of course, about my new health problems.
So, Tony, what are you? You have experience, as you've told us. Go ahead.
Yeah, they do offer now a wireless lead, or I don't know if they call them leads, but they're wireless ends for a pacemaker. So if you do have to go into that procedure, then you might want to consider asking them to use wireless connections.
Okay, can you tell me, or somebody tell me what's involved in putting in a pacemaker?
So
I know that.
I think I'd like to take that conversation offline because we've got too many people today.
Okay, got it.
Is there anybody who has a pacemaker who can share their experience with Joel offline? So Frank can, and so Frank and Tony, would you please email in the chat? Please email Joel with your information, and Joel will pick it up out of the chat, and then you guys can talk on the phone or do something similar.
Yeah, that's fine with me. Thank you very much, Rick.
Okay. So I'm keeping an eye on the clock here, and since we were talking about Dr. E, let's go to Al Latimer next.
Yeah, hi. Two Dr. E's in a row. So I hadn't met Dr. E before, but I had a meeting with her last week, and she did a bunch of tests. And I guess the first thing I would say is she's pretty frank about her evaluation of your situation. So what did she tell me? Oh, she said, "Oh, I see you had Provenge. Provenge is a waste of time. You shouldn't have done that. I see you had a second round of Pluvicto. You shouldn't have done that either because it's dangerous to do more than 6 Pluvictos. Um, I see you were MS high last summer. You should have done Keytruda and not more Pluvicto." What else? Oh, she said, "Well, I see you're on estrogen. No man should be on estrogen. It's very dangerous." So, having said all that, though, she had me run a bunch of tests, and I have a follow-up meeting with her this Thursday virtually, and I guess we'll see what she has to say. Um, I don't really know. I guess I should also say I've gotten some of those tests back already. She did another PSMA PET. It showed a couple more lymph nodes than were there before, but no bone, no prostate bed, which is consistent. She did an FDG, and an MRI as well. They seem to be consistent with the PSMA PET, so no other Mets were discovered, at least as far as I could tell. Um, when I did I did 4 more Pluvictos. The last one was December 1st. My PSA at that time after that was 7. It's up to 19 again now, 3 months later. In the meantime, having been off that now for 3 months, I am feeling a lot better. Not napping anymore. My dry mouth has gotten better. Fatigue has gotten better. My white blood count has gotten better, and so I'm feeling good. And of course, I've been out of town for a month. We were tooling around Australia and New Zealand for a month, so that was nice that I was feeling well doing that. But now I have another meeting with Dr. E, and I would be interested to see what she has to say about what I should be doing going forward. So that's my story.
Did she give you any clue as to what she was leaning towards? She told you a lot of things she wasn't leaning towards.
Well, I think she's still leaning toward Keytruda. Now, I also should mention, she redid the genetic studies, and I don't have that back yet. Well, I'm a little suspicious about the Guardant one I had that showed that I was MSI high, because I'd had a number of those before that, and they never had showed very much at all. And MSI appeared just all of a sudden. It wasn't a gradual thing. So I don't know if that's a normal thing it could be that way or not. But regardless, she's redone it using Tempest, and I just don't know the results of those yet. But to answer your question, I think she was leaning toward doing the Keytruda and trying to supercharge it with something else. I think that's where she was leaning, but I don't know. Like I said, I don't know yet.
Well, she is straightforward. She says what's on her mind, and some people are grateful for that. I don't necessarily agree with her on a couple of those issues, but she has a lot more experience than I do. But I certainly don't think that doing the Provenge put you in bad stead. I do know she doesn't like Guardant, and so that's probably why she redid and those tests. And we've discouraged. I mean, we tend to discourage Guardant.
Well, she said that it's not that she doesn't like Guardant. It's just that Tempest tests more things. It's a more complete analysis. That was the gist I got from her on it. That
Well, there's probably more to it than that. Peter, what's on your mind?
Well, I was going to go to that too, but I'll talk more about it when it's my turn. Who ordered the garden for you?
Schultz,
Schultz?
mostly Schultz.
Okay, I'll talk more about that. And was it liquid or tissue?
The Guardant?
Yeah.
It was liquid, and the doctor
Okay.
before Scholl's, Dr. Meyer, he also did the garden a couple of times.
Okay.
Yeah.
When it's my turn, I'll talk a little bit more about my garden experience.
Okay. So Gary Peters, what's your hands up? What would you like to contribute?
Did she take you off the estrogen now?
No, that was put on the back burner for the time being. I mean, I've been on the estrogen for 15 years, and I don't I, I don't know. I've been on Lupron before that. I feel much better on the estrogen, and I don't feel like I've had any side effects. I don't have any heart problems. I don't know. First, I've heard of it that someone was quite that adamant about not using estrogen.
Are you doing the transdermal patches?
That's correct. Yes, and my testosterone is 1.
Thanks.
Well, I mean, Len, I'll come to you, but again, another strategy, what we've been talking about here today are these second line therapies, these second line monotherapies.
Well, you're
So,
talking about like Xtandi and Zytiga.
or darolutamide.
Well, I've failed all of those.
Well, yes, but I think that, well, I don't want to say. I mean, that's another. The fact is, you failed everything out. I mean, nothing is
There's no
nothing.
question about
Look,
that.
I mean, you just finished, and your PSA's back up to 19. But we know that you make a lot of PSA, and the question is, what keeps you most stable? I mean, you failed, for all intents and purposes, you failed estrogen. What
I've definitely
you could
failed.
stop the estrogen patches and start doing darolutamide, monotherapy darolutamide, and see if that makes a difference. Why do you still do the estrogen?
Well, I've been following. Dr. Schultz has been my main consultant for the last 5 years, and he hasn't suggested I go off of it.
Maybe the discussion is with him or with Dr. E. What about moving, instead of going to the estrogen, what about moving to a monotherapy second line anti-androgen?
I'm not against trying that. That has never been suggested.
Well, it's worth a discussion. Len, what's on your mind?
Yeah, Al mentioning that Dr. E said you shouldn't have gone on a second regimen of Pluvicto because it's dangerous reminded me that the last conversation I had with Dr. Guanchel down here in Florida, she said that they're seeing, with increased use of Pluvicto, they're seeing more leukemias as secondary cancers. So, just a note for everybody out there who might be thinking of trying any of those radioligand therapies more than once, be forewarned.
Yeah. Well, I just think we don't know. And that's why we've been looking for more evidence on retreatment. And the problem is that it takes a long time to see these impacts, to see these effects.
Yes, for sure. Anyway, I have a meeting with her Thursday morning, and I talk to Dr. Scholes again soon also, and will be interesting to see what she thinks I should do.
Right. Jimmy, what's your contribution on this
I was
topic?
only going to say, with the talk about estrogen, can you imagine what Wasserstein would have to say about this? I mean, he's such a proponent of estrogen, has been using
Well,
it for
I don't know what he would say, but I mean, I do know that, if you take a therapy for a long time, and it stops working, the question is, what's the benefit in continuing it? And you know, nowadays they tend not to keep men who are advanced metastatic necessarily on Lupron, but they'll try other things. They'll try the monotherapies. I
Well,
don't know.
Dr. Scholes wanted me to keep my testosterone low, that he
Hmm.
didn't want it to come up again. Well, darolutamide would do the same thing. It would keep my testosterone down.
No, it would not. And you might feel a lot better for it. And the question is, would you be any worse off? But that's why you're getting a second opinion.
Oh, absolutely. That's why I'm getting a fresh look.
That's exactly right.
And I'm not really getting any great counsel locally from Dr. Singal, so I'm
No,
not really relying on him.
no. Well, you know, I mean, I don't want to sound like a broken record, but you know what our response to that is, I think.
Yes, I do. Well, it was convenient because I was going to do the Provenge, and I was looking for somewhere to do it locally, and turned out it was University of Miami, and I ended up in his clinic. And
Right,
I mean, that went
right,
fine, and the chemo went fine with the University of Miami, but that wasn't really directed by him.
right.
Um,
Right. Well, you have another good option there, and we keep getting we get continuing good feedback. Maybe you and Dr. Jack should meet for lunch sometime soon,
that's probably a good
halfway
idea.
between Key Biscayne and Fort Lauderdale.
So,
The two of you should have a lunch meeting.
so you have, so you are seeing Belusic, correct? So, is he still
Yes,
here?
He's nodding his head.
Okay.
I am seeing Belusic, yes. Very satisfied with him.
Yeah, I think, well, depending on where I go from here, I definitely want to get him. I've seen him once.
Why only once?
Well, and that was recently.
Okay.
Um,
Well, look, yeah, do you know how to reach each other? Can you use the chat window to exchange? If not, reach out to me and I'll make sure that you have, or reach out to David Muslin and he'll make sure that he connects you.
okay. Well, I'll put my,
Jack's yeah, Jack's on the phone. Jack, I don't know if you can get to the chat, how easily you can get to the chat window, but make a note.
Okay.
It makes it
well,
easier for me. Makes one thing less for me to do tomorrow if you guys can take it off of the chat window.
Jack,
But if you cannot, let me know.
Jack, do you want to write down my phone number?
Yeah, sure. Hold on. I was in the chat room right now. Go ahead, Al.
Oh, you're
What's
in
your
the
phone
chat
number?
room?
No, go ahead. Give me your phone number out loud, huh? Yeah.
954-683-8949.
I'll give you a call.
Okay. Thanks, Jack.
Perfect. Thank you, Al. All right, I got to keep moving through, and let's go to since you raised it. Let's go to Peter, because you obviously have some feedback on some of the things we've been talking about today, Peter.
Okay, I'll try to keep it quick here and streamline this. So yes, I too had a Guardant 360 test ordered by Dr. Schultz recently. Was a liquid biopsy test. They sent over a phlebotomist flew over to Maui, met me at the airport on a Sunday morning just for this, and she took the blood in the parking lot, and then we and flew back. Anyway, results were strange, and this is not the first test I've had. I've done a Caris test. I've done a foundation medicine test. The foundation medicine was done about 5 years ago or so, or 2018, I think, and that was a liquid biopsy as well. And my Caris test was from tumor tissue, and that was done in 2020 um, from a biopsy that I had then. So oddly enough, the Guardant one came back with some odd findings. One, the MSI high that had been reported by Caris 4 years ago came back as non-detect for MSI high from Guardant, but it was also non-detect from the liquid biopsy that Foundation Medicine did. So it makes me start to think maybe liquid biopsies are not the best for MSI, but what do I know? I'm just reporting here. The tumor mutational burden, the TMB that Guardant found, was low. Every other one I've done had high tumor burden. So go figure that one. The only thing that the Guardant found was my germline Lynch syndrome MSH6 mutation. It did not have any, did not find any BRCA mutation. However, the Foundation Medicine one and the Caris one found that I had a somatic BRCA2 mutation. So go figure that. So when I met online with Dr. Schultz last week to go over this, I mentioned to him, I said, why Guardant 360? And he seemed to not know or care much about it. And I said, well, I'm suspicious about them. I've heard they're not very good. And Schultz said, yeah, well, next time let's do a Foundation Medicine one. I mean, he seemed, it didn't sound like he was invested in the company. I don't know why it was picked, but just a heads up that it might not be the best choice if it comes up again for any of you. So that's the short story of my Guardant 360 experience. I had talked to Rick about it, because I knew that there was some question about it, and he'd mentioned that Dr. E was not very happy with them, and so I think I'm not happy with them either. There's just too many questions I have.
Peter, this recent test was after you did all the Keytruda, right?
Yes.
So do you think that affects the results?
It could. I don't know. There's no way to tell. So
did you ask Dr. S, Dr. Schultz?
Yeah, but he can't. I mean,
he doesn't know.
Nobody's a mind reader in this. You really, when you get far along in this stuff, you really don't know. Nobody can read the tea leaves in this stuff. So that brings me to my next thought, which is I did a
Peter.
Okay.
Hold on, Peter. Hold on. One thing. When did you do that FMI test? How long ago?
That was 2018.
Yeah. So you can't be comparing tests.
No, you can't.
Too many things change in between. You can't say, well, it's weird that FMI showed this. It's weird that Caris showed that. We don't know. You may no longer make it. So, I mean, thank God they saw the MSH6. If they hadn't have seen the MSH6 and you thought that could have gone back to wild type, I would have said, well, that is a bit weird. But the fact that these other things happen, when you say who knows, well, this is why we say you've got to test at regular basis, because things do change. At the same time, if it were me, I might try to push to get a Tempus or a Foundation Medicine liquid biopsy right now and see how they compare.
I doubt my insurance would go for that 2 weeks after the last one. That would be a stretch.
Well,
I could ask, but I really doubt it.
Yeah, but it's not your insurance who should be asking. It's one of your three doctors. Let Antanarakis order it.
Yeah, maybe when he can't
don't
do that.
You try and ask.
He can't do that now because he can't practice in Hawaii. But when I get to Minnesota, I'll ask him for sure. That's a good question. I've thought about that. But anyway, it's I don't even think these testing companies can give you answers on this stuff. It's who knows is the way I go. So that brings me to the PSMA test, which I did recently, and the PSMA test showed when we did a scan-to-scan review, not not a report-to-report review, but a scan-to-scan review, it disc to disc, that showed that my Mets had decreased a fair bit. And they're in a funny area in my peritoneal cavity, but it showed a decrease. However, my PSA has gone up a little bit, and it's not doubling very rapidly at all or anything like that. It went up like 0.5 in 6 weeks, so it's at 2.5 now. And my chat with Schultz was that, well, he said, well, maybe you could do a quarter dose of olaparib, start at a low dose. And I said, oh, that's interesting. And I also talked to Antanarakis through my chart thing about this. And my plan right now, because is to just monitor for a month or two and see where my PSA goes. And if it starts looking like it's climbing or getting out of hand or really going up significantly, I could start with a quarter dose of olaparib and see where that takes it. Or with Antanarakis thought I could probably wait until I get to Minnesota and maybe start then when I get there. So
this sounds like throwing spaghetti at the wall. I mean, I just read today a study by FMI where they reviewed hundreds of records of people who took olaparib monotherapy. And the distinct conclusion, which Len and I told them 4 bloody years ago, was that it only works if you've got BRCA1 or BRCA2. Now, whether you take a quarter dose or a whole dose, it is toxic. And why are you taking it if there's no reason to say that it works? And if you want, remind me tomorrow and I'll forward the study to you. I saved it. It was one of the studies that I didn't see it until I had some spare time today, and I looked at the FMI studies that were posters that were at GU ASCO. And this is a poster with Ryan Graff, who we know well. And it's very, very clear. It doesn't do anything unless you've got a BRCA1 or BRCA2 mutation. And if you don't have somatic BRCA1 or BRCA2 anymore, I don't see the point.
Well, both Foundation Medicine and Caris, 2 years apart, found BRCA2, but Guardant didn't report it. So, I mean, am I throwing spaghetti at the wall? I don't know.
Peter, how long ago was Caris?
4 years ago, and that was tumor tissue.
And how long ago was FMI? And how long ago was FMI?
6 years ago.
There you go. So whatever is somatic can change from even in a year it can change. The fact that they found
it can. I agree with you. It can, but it also could be Guardant just didn't pick it up. Until I get more information, I do not know.
Yeah, well, I would say I would put it more on the fact that your body has changed over that period of time, and there is no good reason today to use olaparib. Dr. Bob, what did you want to say?
I just wanted to say that I've been doing a good bit of research, and it seems that different companies have different thresholds for reporting. So Guardant might pick, 4% as a threshold for reporting, whereas Tempest might use 2%, and someone else might use 6%. So just because it's not showing doesn't mean, what you might want to see is if you can get the raw data and see if maybe it's there in the low amount and it's just they're not reporting it because their system doesn't report at that level. Just a thought.
Yeah, that's possible. I mean, I guess my question to all of you is, how many of you have beat a somatic mutation by your treatment? How many of you no longer have a BRCA2 or a TPS3 or whatever? I mean, anything. Have things disappeared on you because of treatment? I guess would be
Well,
ask a good question.
look, let's not call it beat a mutation. The mutations change. They just the same way with Professor Bill. His BRCA went to wild. His BRCA germline went back to wild type. So I don't know. Is there anybody here who has had a somatic mutation on one test and not had it on another test? But we've
This
seen
is
it.
Al. This is Al. Yes, I've had BRCA on well, two gardens ago. I had a BRCA mutation, but not since.
I mean
Same garden.
that's the difference between somatic and germline. Len, go ahead, please.
Yeah, well, I had BRCA2 reported way back in 2014 when I was first diagnosed, but then in 2019, 5 years later, I had the bone biopsy at the NIH, and they did not pick up BRCA2. I never had a PARP inhibitor, so was it just not in that particular lesion, and maybe it's elsewhere? Who knows? But the other thing I wanted to say, Peter, is in this ASCO GU conference, they did a study comparing patients who had Pluvicto with or without a prior PARP inhibitor. And it was shocking. If you had a PARP inhibitor and then subsequently did Pluvicto, the Pluvicto was practically useless. It was like worse than trying to follow up a second line anti-androgen with another second line anti-androgen. We know that works very poorly. And the results from this study with olaparib and then Pluvicto was just as bad, if not worse. Something to talk about with Schultz or Antanarakis.
Yeah.
And I just put that FMI study in the chat window, the one that I read today, Peter.
Okay. Yes. 10 years into this, my quality of life is very important to me right now. You might think I'm crazy just prioritizing that, but I feel pretty good, and I'm not ready to just throw my body to the wolves right now and just jump on anything. I can live with a 2.5 PSA that went up half a point in 6 weeks. I'm not panicking about this. I'll see where it goes, and when it's time to start treatment, I will do it. But I'm just being cautious right now and enjoying life.
Well, I agree with you. That's why I'm saying, why would you start the olaparib? And I'd say something more than that. The fact is, your cancer doesn't show up anywhere except in the peritoneal cavity, and you've been fighting that forever and a day. And if we were really, I'm a lot less concerned and a lot happier to hear that than if you would have come back to me and said, well, they saw a spot here or they saw a spot here. We don't see it anywhere else with you, and
exactly. And nothing new. Nothing new, and it hasn't grown. It's shrunk. So that's plus.
All right, Dr. Bob, did you have your hand up again, or did I just forget to take it down?
No, just real quick. It seems like the heterogeneity of the cancer plays a role. I had testing originally on my biopsy that showed MSI high. I had my biopsy samples retested more recently. Same biopsy, same, from the same time. No MSI high. So, it's like hit or miss on these tests. If they hit the right spot, you get one result. They hit a different spot, you might get a different result.
So that was the same company that gave you a different result from the same tissue?
Different company.
And who
Interesting.
was the second company that didn't see MSI high?
It was Boston Gene.
And who was it that saw MSI high?
That was Caris.
Okay. I mean, I don't know enough about Boston Gene. We have no experience with them. I think Caris is pretty reliable, but I can't
Yeah,
comment on Boston Gene.
yeah,
Just
they're,
I don't know.
yeah. MD Anderson pretty much uses them exclusively, and so
But that's not a testimony for me.
no, I
I mean, that
understand.
MD Anderson uses them exclusively maybe an issue with MD Anderson. That's how
Yeah,
I see that.
yeah.
You know,
Point
why do
is,
they use them and other people will use different people? But I don't
yeah.
know.
My point is that the heterogeneity can affect your result. That was
Was
my only
that
point.
was that tissue or was that blood that they saw the MSI high?
Tissue.
Again, I tend to favor blood because it's a much more of a cross section, and you
Yeah,
know you're not
I had.
seeing going in one part and one in another part. Look,
Yeah, well, I had.
we've got to move on. We've got to move on.
Yep.
Frank Fabish. Frank.
Yes, gotcha. I had my PSMA test on 214. Just as a sidelight, today I got from the VA the cost of that test, and it was $18,723. If anybody wants to know
Yeah,
what the cost
but
was,
Frank. Let's go to the point. These costs don't mean anything. This is like they pull it out of the air. Nobody pays that amount.
right?
Nobody. Okay, you don't pay it if you pay cash. The insurance
No.
company doesn't pay it. Nobody pays it. So let's not, you know, we've got 8 minutes left, 4 guys to go. Let's please get to the point.
Okay. My PSMA test showed that the only cancer I had still remained in my lungs with the 4 nodules in my lungs. It wasn't anywhere else in my body. Uh, Surprisingly, I met with my doc a week later to review the test, and this was 2.5 weeks after I was in before, and they decided to take another blood draw. And during that 2.5 weeks time, my PSA moved from from 0.97 to 1.44 in 2 weeks. And as a result of the PSMA test, my doc looked at me and he said, okay, I have considered 2 new treatments for you. One is either PARP inhibitor, because I do have a BRCA2, or the other is Pluvicto. And he said, based upon your conditions, I'm recommending Pluvicto, 6 treatments. And to start, I'll be having my first one Thursday of this week. He said 2 days before each treatment, they will do a blood draw to check my blood counts to make sure how everything is in line. He said during this time of the treatments, I'm taking you off of the abiraterone prednisone, and you're only going to be on Ergovix. And so I go in tomorrow for my blood draw. I'll see where my PSA is tomorrow, and then Thursday I'll get my first Pluvicto treatment.
So
That's
you were somatic BRCA, correct?
somatic, correct.
Right.
And that was a tumor tissue that was sent out to Foundation One.
How many years ago?
That was 5 months ago.
Okay. So,
And
again, you just don't know how extensive it is. And as Len said, if you do the olaparib, then you're probably going to have issues with trying to follow up with Pluvicto. This is what they're seeing. So I think it's probably smart to do the Pluvicto right now. Have you done an FDG scan?
we talked about the FDG scan, and I said I want to discuss it with you because it's recommended that I get it. And he said, this is why I don't think it's necessary. He said, all of your scans, as I look back starting 4 years ago with your Oxyman PET scan to the CT scans with and without contrast, numerous ones, bone scans, and MRIs, it hasn't shown any cancer outside your lungs. He said, and because of your health, that I don't see any other issues. He said, I think we can always do the FTG after we start the Pluvicto, if that's not successful. But he said, right now, I just want to get you started on the first treatment to get started and to see what the effect is going to have.
So when was the last time you had either an FDG scan or a bone scan?
I had a bone scan approximately a year ago. In between, I've had an MRI. I've had 3 different CT scans, 2 of them with contrast, 1 without. And I had the Oxyman PET scan 3.5 years ago.
Okay. But recently, in the last year, what scans have you had other than PSM?
Bone scan and CT scans.
Okay. And when was that last CT scan?
The last CT scan was 8 weeks ago.
Okay. And so what Dr. What's his name? I always forget his name. Yeah.
Mortazavi.
Yeah. So what Dr. Mortazavi is saying is you had a scan 8 weeks ago. Was that an FDG PET scan that you did? That
No,
PET scan?
no, I had the CT scan 8 weeks ago without contrast to see if the lesions, the nodules, were growing at all. And he did a comparison of the data, and he didn't find any growth in them. And then the PSMA scan, that's when they limited it to the 4 nodules in the lungs.
Yeah. Len, when they do that FDG PET, what equipment are they using? Aren't they using a CT scanner?
Yeah, they use a CT scan just like they do when they do PSMA PET.
That's
It's
what I
PSMA
thought.
PET CT.
Yeah.
Yeah, the
So
CT is low resolution just for anatomical location.
for with the PSMA, but what he's saying is he had a proper PSMA, he had a proper CT scan. Frank, that could have been an FDG PET scan. It could easily have been. When you have a CT scan, they've got to use something. It's not just with or without contrast is another issue, but they do an FDG PET scan using a CT, and I think what Mortazavi is saying is you had a scan that would have identified cancer anywhere in the body 8 weeks ago, which if that's the case, I would say, yeah, that makes sense. But I don't know for sure. But whatever that scan was you had 8 weeks ago, it would be good to know exactly what it was.
I'll bring that up to him tomorrow morning. I'm in there at 6:45, so it'll be an early discussion.
Okay. All right. Let me tell you.
That's why the what they talked about with Pluvicto tonight was very appropriate with me going to go through that with the first treatment on Thursday.
Okay. So I still have.
Excuse me, Frank. You said that you were going to drop, I believe, prednisone.
Going to drop the abiraterone and prednisone. The prednisone, they're having me start to step down from it.
Oh, good.
I'm to
Okay,
drop the
thank you.
abiraterone, and then over 6 weeks, they're going to step me down on the prednisone.
Okay.
Thanks. Good catch.
And
All
one
right.
other thing is they're going to infuse Zofran ahead of the Pluvicto. And they're going to give me some Zofran to take home in case of nausea.
Okay. So we've got 3 people left, and I'll hang in for all 3 because it's now the top of the hour. We've got Joe, we've got Jimmy, and we've got Gaoshan. So let me start with Joe.
You're muted,
Joe,
Joe.
you're muted.
Sorry. I was going to say I'll skip it this week.
Are you sure?
Yeah.
You got the audience. Who knows what we got next week?
All right. I'll do it. My problem seems so trivial compared to some of yours.
Let me stop you. Nobody's problem in this group is trivial. Nobody's. And please, anybody's got something they want to raise, we want to talk to you about it. We want to try and figure it out. We want to brainstorm it. Everybody's at a different stage in their disease, and everything has important where you are right now. And so please don't ever think that you're not important enough to talk. Go ahead.
Okay. I had a PSA test on Tuesday of last week and talked with PSMA test, scan, and talked with my medical oncologist on Friday about it. There were 2 spots in lymph nodes on the PSMA test. First time I've had 2. Always had 1. It seemed obvious to me that I should just radiate it. They're concerned about not doing that because one of the spots is very close to another place that's already been radiated. I'll talk to a radio oncologist about that next time I meet with her, and just wondered if you had any thoughts about that. I guess one question is, should I give up on this game and go with hormone therapy, which is kind of what everybody talks about, or should I continue playing this game for as long as I can?
I'm going to let Len take that one on.
Sorry, stretching out my back there.
That's okay.
Yeah, Joe, yeah, I faced the same dilemma. I'm coming off of a drug holiday. PSMA PET scan showed a couple of lymph nodes, couple of small bone mets. And I had a consult with a radiologist, radiation oncologist, and they had the same concern. Well, this looks like it might be an area that was previously radiated, so we don't want to do that. And so they recommended just hormone therapy, which is what I'm on, and it has brought down the PSA to a near undetectable level. So, have you had any radiation proctitis issues?
No, I've never really had any side effects from that.
Yeah, well, of course, it's a decision that only you can make. Do you want to play it safe with just the hormone therapy, or do you want to try and kill the cells with radiation, with the risk that you may wind up with some side effects that you wish you didn't have?
Hmm.
But of course, we all need to keep in mind that hormonal therapy doesn't typically kill cancer cells. It's kind of a parking place, right? Uh,
Right.
it At best it puts them in a dormant state, just slows the growth. So those are the things you have to consider.
The other thing, Joe, that you might want to think about is getting a second opinion on the radiation from somebody who didn't radiate you before. And I would suggest you have a real good option with Dr. Vapiwala at Penn. She's really not, she's really compassionate. She's great. We really like her. She's in your area. And ask her what she thinks.
Could you put her name in the chat, please?
I will. I will. I will. I will. What do other people think here?
Well, if you go to another radiation oncologist, make sure you get the original radiation plan from the first oncologist, so they know exactly what areas were radiated.
Okay.
Right, here you go. I'm going to put it in the chat window right now. It's Dr. Nia Vapiwala, and we've sent several people to her, and she's really great. And that's there you go. So you might want to think about a second opinion. She understands hormone therapy really, really well. So, and
Thank you.
Dr. Bob, if you haven't gone, you didn't speak too much. You're fine. You're absolutely fine. That's what makes these these sessions so good. Okay? We all have different opinions. Most of the time, none of us are right. So, so you did just fine, and we're glad to have seen you. Anybody else have anything they want? This is another good conversation. I mean, do you hang on to whack-a-mole as long as you can? When do you get in? I mean, I don't know whether they've ever done a study of whack-a-mole versus early adoption of hormone therapy. Do you know that, Len? That's the sort of thing you might have looked at.
Well, they do claim that you can delay systemic treatment of any kind if you have a successful spot radiation treatment. But I'm not clear on whether you need to radiate every positive lesion or just one. So I think in other words, I think you need to radiate all the positive lesions in order to get that extension of progression-free survival before you need to go on some form of systemic therapy.
Well,
So
I did.
I was going to offer that. So these are really one of the classic tough ones because I've been to major institutions here in Houston, not to name them, and there were divergent opinions as to what you're supposed to do. Right? I had prostate surgery, and then I had a relapse, and I waited for it to move up a little bit. There were those who say, wait longer, and I said, hell no. I talked to some radiation guys, and we said, look, let's go after the whole thing, throw the kitchen sink at it. So we did the radiation, and also went on 18 months of ADT, using Orgovex. And we'll see. I came off that about 6 months ago, and next week I'll peek underneath the rock again and see where I'm at. But that was just a choice of, the radiation guy says, if you want to delay and extend your time period, then you need radiation. Otherwise, you're going to be a statistical. You're counting on the radiation alone to do it. I mean, on the hormone to do it. So it
Yeah,
is a
but this
personal.
is the reverse, which is when do you start the hormone therapy? It's not you're on the hormone therapy, you see the spots, we should radiate, but here we've got the reverse. And Phil, we'd love to hear more about your story, and try and come in next week and get in here in the first 10 minutes, and we'll definitely poll you and we'll give you time.
Great.
But I don't know anyone else who has delayed hormone therapy with a whack-a-mole strategy. Anyone else in the group? We've had plenty of people. Joe, I don't know. I kind of like the idea of getting a second opinion from Dr. V. She's independent of Fox Chase. She's very knowledgeable. She understands hormone therapy real well. She's compassionate. She's very smart. So, I would say go with that. I got to keep going because people are dropping like flies, so let me go. Let me go to Jimmy and then to Gaoshan.
Rick, I'll definitely wait. Okay, it's fine.
You want to wait?
Yeah,
Okay.
fine.
Gaoshan, you had a question.
Yeah. My last PSA test in February was 0.001, same as it was 6 months earlier. My testosterone rose from 40 to 406. I have to have a PET CT FDG scan for not related to my prostate cancer, but for another reason. My question would be, I believe they're going to use a glucose mixture with the test, because my PSA is very low, and they're going to be looking for some other type of cancer. Would any of the if I was to have any lesions with a PSA that low, would they show up, or would it only show up for something else they're looking for?
Well, I mean, what's going to show up is any place where the cells are dividing very quickly.
Okay,
That's
that's
what
what I
the
thought. But
FDG.
there's no way to differentiate what they are, except to see if they're dividing quickly and where they are. Correct?
It's just going to show you where there's a lot of activity. But let me defer. To Len, because he's much better on this stuff than I am.
Well, you got it right, Rick. Yeah, FDG stands for fluorodeoxyglucose. So it's
Right. That's what I'm going to
glucose.
have.
Yeah,
Right.
and so any cell that's rapidly growing or dividing
Is
needs
going to show up
glucose.
in that scan, whether it's something else or prostate cancer.
Any cancer at all, they need
Okay,
glucose.
that's what I thought.
But
Okay.
it won't. Yeah, the scan itself won't tell you what type of
Right.
cancer.
No,
Yeah.
yeah, that's what I thought. Okay. Very good. Thank you.
Okay, last call, Jimmy. Last call. You sure? I guess he's sure. He's not switching on his microphone.
Sorry,
We
actually,
kind of
I
forget.
said, it's a smart ass anyway. I said, I take a gamble that I'll be around for the next time.
Oh, but wait a minute. It's a Tuesday. You don't come in on
I'm
Tuesdays.
coming in on Tuesday, mister.
All right.
James.
You'll be number one. Peter Kafka, put him as number one after the newbies, okay?
How much is it worth to you, Jimmy?
Well, it is. You had Schultz fly out to Hawaii to see you. I don't think you need anything.
Okay.
Oh boy. All right, now guys, just a quick promotion, and I'll put it in. But I did do Solo Arts Heal with my best buddy last Wednesday. It was a lot of fun. He was up at 2:30 in the morning from the UK. We did two or three of his songs. He showed a bunch of slides on the art of the breast and other aspects of the breast, which he's given at many large medical conferences. We had a good time, and that recording should be available pretty soon. I'll put it in the reminder, and it might be a fun one. It might be a fun one to watch. And actually, Jimmy, I got to talk to you about Solo Arts Heal as well. So,
Okay.
all right. We got through everybody, kinda. Sorry, Jimmy.
That's no project to me. It was a good discussion tonight on everything. I liked it.
Okay. Yeah, we did. We had a lot of good stuff. And all being well, Peter will be back with you next week. I will too, but Peter will be leading the show next week. Who knows what he's going to write for us for next week? We don't know. It's a mystery at this point in time, but he'll write something. All right.
Good night, everybody.
Good night, all.
Thank you very much. Good night.
Thank you.